So today our group is going to discuss restraints, the myths, and the risks. We have Sally, myself, Jaden, Casey, Debbie, and Chenny. We're first going to do a land acknowledgement. So we would like to take a moment to acknowledge the privilege that we have to gather today on the unceded traditional territory of the Latine, and Prince George, and the Lataco, Dene, and Quinault. We are grateful to the Indigenous populations of these lands for allowing us to live, work, and play as an uninvited visitor. We commit to further developing and fostering our relationships with the Indigenous peoples and to work together to preserve the beautiful lands in which we all call home. Restraints have been used historically for the protection of the patient and for the security of the patient and staff, control behavior, prevent falls, altered mental status, wandering, patient harming themselves, agitation, interference with treatment. Restraints are physical, chemical, or environmental measures used to control the physical or behavioral activities of a person or a portion of his or her body. Physical restraints are meant to limit a person's movement. Chemical restraints are use of medication, particularly psychotropics. Environmental restraints control a person's mobility. Potential effects and risks of restraints on the elderly population are prolonged hospital stay, physical or psychological harm, loss of dignity, violation of rights, hinders self-reliance, and death. Fun fact, physical restraints also raise the ethical issues of hindering self-reliance of older patients and disrespecting their autonomy and dignity. As well, delirium and agitation are some of the most common reasons to use physical restraints in an acute setting.
The statistics of restraint use. As shown in the graphs, chemical and physical restraints have increased, although physical restraints more than chemical, and the numbers have been adjusted for dementia patients, leading to the conclusion of the pandemic affecting the increase of use in restraints in general. Prevalence. The use of restraints throughout hospitals in Canada, pharmacological being the most used of all forms. Seclusion, used mostly in psychiatric units for the safety of patients and staff. Physical restraints are often used for fall prevention, and pharmacological restraints are used for managing patients with violence and aggression. The biomedical model in nursing focuses on keeping elderly patients safe and to prevent falls, although this leads to many nurses restraining their patients to prevent falls and minimize mobility. To advance this area of healthcare requires a thorough review from policymakers, clinical leads, and researchers. Thought-provoking questions to ask yourself before using restraints. Is the use of the restraint within my moral beliefs? Have all other options been exhausted? Is this to help the patient or yourself? Will this harm the patient? And will this cause trauma?
Restraints should only be used in serious situations as a final resort and only when nurses are legally permitted to. RNs don't need an order to employ restraints when the circumstance is a non-emergency unless stated otherwise by their workplace policies. In emergency situations outside of the patient being an immediate threat or at imminent risk, RNs must have a legal order before applying restraints. To apply restraints, nurses must obtain consent from the client or the client's substitute decision maker or have legal authority overriding the consent requirement. Having the competencies to use restraints safely, follow their employees' restraint policy, follow BCCNM's consent practice standards and employee policies when obtaining consent. Using restraints can be detrimental to a patient's mental and physical well-being. The use of restraints should be ceased as soon as possible, and nurses should make sure that the client's health, safety, and status are maintained in accordance with the workplace policy. Monitoring the patient, completing the appropriate documentation, and following the professional standards are necessary. A thought-provoking fact is that without legalization or legal grounds, confining somebody under restraints or seclusion is an assault and a crime.
To bust the myths of restraint use, I'll be addressing 3 myths. Myth number 1 is using physical restraints prevents elderly patients from falling and injuring themselves. There's actually no scientific research that supports the assumption that restraints prevent injury, and on the contrary, research indicates that risk of injury increases with restraint use. Myth number 2, restraints when used properly won't harm the patient. So even when the restraints are properly applied, restraints can still lead to serious complications related to immobility. For example, decreased muscle mass, bone demineralization, and pressure ulcers. Restraints can also increase the likelihood of contusions, neurovascular compromise, nosocomial infections, chronic constipation, and incontinence. Myth number 3, alternatives to restraints do not exist. There are actually many restraint alternatives. The first one is physiological care, such as comfort and pain relief. Second is psychological care, including companionship and supervision. Third is activities or planned recreation. Fourth is better environment, such as rearranging furniture. And lastly is staff education. Fun fact on restraints is when it's properly implemented, restraint reduction doesn't require an increase in staff and can be cost-effective due to fewer health complications and lower morbidity rate. Many features of restraint reduction programs include door alarms, anti-slippers on wheelchairs, and bed with wheels removed.
Is it beneficial? So, depending on the patient's situation and nurse assessment, restraints may be used to prevent self-injury, such as falling from the bed or mobilizing without assisted devices. If other therapy or interventions are ineffective, a comprehensive patient assessment must determine the nature and application of restraint. What are the gaps and barriers in restraint use? The usage of physical restraint is a significant global healthcare concern. So, inadequate education for nurses about physical restraint use, lack of standard guidelines for physical restraint use, insufficient standard physical restraint equipment, disregarding patients' holistic health and right, ignoring the emotional and mental distress restraints affect the restraint has on patients and their family, the inability to find an appropriate alternative for physical restraint. So ethical dilemma. While nurses must balance the benefits of using restraints against the benefits of using them, and they must take the patient's safety and autonomy into account. The decision to employ restraint is sometimes frowned upon with ethical questions. It is advised that health authorities create a concise, evidence-based guidelines for the use of restraint, as well as create and implement nurse education, counseling, programs on the ethics of nursing practice, patients' rights, restraint guidelines and protocols, and handling of emotional, ethical, and legal issues. Thought-provoking information. International studies in different countries show that the use of physical restraint is about 87% in the US, it is about 76% in Canada, and 50% in France. And the lower prevalence is in Norway, which has 14.36%, in Germany, 11%, and Australia, 7%.
So these are our references, and thank you for listening to our presentation.